I'm no good at taking good advice, and I'm self-careless, so don't tell me twice that lately I've been so stuck in my head that I forget just about everything my therapist said. Maybe I'm self-helpless, maybe I'm self-helpless. Maybe I'm self-helpless. Maybe we are all self-helpless.
Hey everyone, welcome to Self-Helpless. I'm Delanie Fischer, and today we have a phenomenal guest. Dr. Natalie Crawford is a board-certified OBGYN, fertility physician, and founder of Fora Fertility in Austin, Texas. And she is debunking all kinds of myths and misinformation about fertility, and it was incredible. And even if you don't want to have kids or conceive at some point, I found this information absolutely fascinating because it's just really about human health and the human body in general. So I learned a ton. And Dr. Natalie shares the biggest misconceptions about some of the tips or hacks out there that many of us have heard about. Everything from does it help to put your legs up in the air after sex if you're trying to get pregnant, to things like should you have sex as often as possible or should you save up your sperm and only have sex during ovulation? She touched on information about foods, the evolution of C-sections, contraception, pregnancy loss, IVF, secondary infertility, the age of 35 for females. We've all heard about this very important age. There's so much in this episode, and I could have asked her 10 hours worth of questions, and we still wouldn't have gotten to everything. She also opens up about her own experience with pregnancy loss, which is something that she went through while she was in process of becoming a fertility doctor. And this topic was submitted and voted on by our patrons over at patreon.com/selfhelpless. Thank you for participating in that. I got to as many of your questions as I could in this episode. What's great is I would ask her one question and then her response would answer the next 5 questions I had for her. So she really packed a lot of information for us in this episode. And if you would like to support the podcast by becoming a patron, where you can submit and vote on topics and other stuff like that, you can join us at patreon.com/selfhelpless. And we really appreciate you so much. All right, everybody, here is my chat with Dr. Natalie. What is the number one biggest misconception or most common one that you hear about when it comes to fertility?
There's so many, it's gonna be
Yeah.
hard to pick just one. Let's pick one
Yes.
for male fertility, kinda one for female, just to kind of kick it off.
Love
The
it.
biggest one that I hear about for female fertility, and I hear this from female physicians, from patients, is that as you get older, this idea that it's not gonna be that hard to get pregnant if you are, taking care of yourself. And the truth is, taking care of yourself, being healthy, the lifestyle choices that you choose matter so much more even as you get older. But the difficulty in conceiving exists purely because of age and degradation for egg quality that happens. And this doesn't mean that people can't get pregnant earlier. I'm a huge proponent that you can take control of things. But it really does mean you have to have better knowledge of your body. You have to be quicker to get an evaluation. And I just see a lot of people drag their feet in this idea it's just going to happen, despite the fact that they are older and potentially miss their window of opportunity. When it comes to men, though, the biggest misconception here is that they need to save up their sperm. And so there's this idea that we're tracking our cycle, trying to pick that ovulation day, and that people should not have sex except for that ovulation day.
Oh
And
my
they
God, I've never heard that. That
Yes,
is so
you'd be shocked at all these patients I see, and it's like this, I
wow.
gotta save it up so that I have all the sperm I can for that ovulation day. But really what they're doing is, building up a lot of debris and dead sperm and almost clogging the pipeline, making it harder for them to actually have the good sperm get through that debris. So that's why it's important, we like to say sex every other day or every couple days so that you're clearing the pipes, you're getting sperm there. Sperm are being made every single day. So you never need to have less sex if you're trying to get pregnant. I think that's one thing that people get so focused on timing it when they ovulate, they actually decrease the amount of opportunities they have intercourse, and they decrease the total amount of good quality sperm that are being presented.
Wow. Okay. So saving your sperm up could actually have an adverse
Yeah.
effect. Oh, I've never heard that. So fascinating. So, as far as age or the window
Mhm.
of opportunity for females, I've heard age 35, it starts to kind of drop off, but I've also read that that is from an old study from the 1700s. What is the accurate information here?
So, first of all, we have to acknowledge that all historic fertility data is very biased because what they
Yeah.
did is they asked people how long it took them to get pregnant, thereby excluding everybody with infertility. So, if
Ah.
you didn't get pregnant, you would never had a time to pregnancy. So, all time to pregnancy data, which based our original how long should it take you, when should you get worried, is truly from cohorts of fertile women or people who did eventually conceive. So there's some bias against people who never got pregnant not being included in some of that data. Also, when we saw lower risks of live birth at age 35, even though a lot of that's true, a lot of that comes from like higher pregnancy complications and higher risk of, genetic abnormalities and miscarriage starting to be seen around that age. We actually see that the egg number, if we're talking about how many eggs you have and your actual fertility rate for most people, doesn't really sharply decline until after 37. Is it lower at 35 than 30? Yes. One of the biggest issues, though, is the age of which you are and where you are in your family planning journey. Meaning, do I worry about a 35, 36-year-old who's trying to have her second or third child? Much less so, because her fertility rate remains high if she got pregnant in the past without much difficulty.
Mm.
Who it impacts significantly is somebody who doesn't have proven infertility. People who've never gotten pregnant, when they start trying to conceive at age 35, 36, they have about a 10 to 12% chance of getting pregnant per month. And then if you're starting for your family at 38, it's 5 to 8%. And so these numbers for per month chance of getting pregnant when you're just starting your family, because you could have issues, you could have blocked tubes, you could have no sperm, you could have something else truly preventing you from getting pregnant, make it so much harder to grow the family you want. And that's why we like to see earlier intervention as people get older. But in contrast to that, the 35, 36-year-old who's had a child in the past still has a 20% chance of pregnancy per month. And the 38-year-old who's had a child in the past has a 15% chance of pregnancy per month. So we see these higher rates in people who've had children in the past, almost an idea of some level of proven fertility. Of course, your ability to get pregnant is a moving target. Things can change over time. Sperm changes, tubes can get blocked. You can develop endometriosis. Your age does play a role. But really, what we see is a large group of women, myself included, people who waiting longer to get pregnant because they are pursuing right career, family, haven't found the right person, and then starting this whole family at a later time. And they are starting with no information because the fertility community, the infertility field, was created to be reactive, right? The default is you get pregnant, and then we
Mm.
react to all the people who haven't gotten pregnant at a year, and now we will do these tests and treatment. And it's really not a field that's preventative or an advocate for early testing. I'm a
Mm.
huge advocate for early testing, for understanding your body, especially as we start to enter into that older age range in context of your whole family. If you're 37, you want multiple kids, you do need to get testing early. You need to know what you're dealing with. How long should you try? Should you consider, fertility treatments to get pregnant faster or for further children? And those are conversations that we're seeing more that people really didn't used to have at all in the past. And I think that shift has been good, but it does lead to a lot of confusing information. People are like, I got pregnant at
Right.
39, fine, but that person might have a whole slew of other kids, and that might not be somebody's experience at 39 trying for their very first.
Right. I'd imagine it has been a challenge for you in your line of work because there's not enough information about just female health in general. Question for you about what you mentioned. Somebody who has had a child before, is that a higher statistic that they can get pregnant only because we have the proof that they can get pregnant? Or is there something about having one kid that makes you more fertile for the next kid? And then somebody's first time getting pregnant, we just don't have the information yet, so that influences the stats that we have?
That's a good question. There's no way to have the true answer, although my professional judgment is that it's that you've proven the parts work. There's some egg
Okay.
and sperm compatibility. You can fertilize an egg in the body. The tubes were open. There was enough sperm to fertilize. Because we know that just the act of a pregnancy carries some risks itself, right? That, if you have a C-section, which are becoming increasingly common, that can cause higher rates of pregnancy difficulties down the road. You
Oh.
have a higher risk of, endometriosis as you age. There's something called adenomyosis, which is where you essentially have the endometrium, which is the lining of the uterus, invades into the muscle area of the uterus after a placenta has been. So, this is a disease that causes a lot of inflammation and trouble getting pregnant later down the road that you don't see almost exclusively. We never say never in medicine in people unless they've had a placenta grow into that muscular layer before. So there's something, pregnancy is never health neutral. Having a placenta grow into a uterus is never benign. There's a whole litany of scar tissue, this, that, and these different circumstances you can fall into. So I don't think it's actually like, oh, once you've been pregnant, your body's going to reprogram or there's something about it that makes you more likely to then be pregnant again. I think it's truly that you've proven, certain competencies in these areas that are must-haves to get pregnant. So you're
Right.
in a higher category of probability that it will happen again. But even in that category, right, secondary infertility is I've been pregnant in the past and I'm having trouble getting pregnant with future children. And that exists, that's real. And that can be very, very hard, especially because there's this loss of belonging to a community, meaning
Mm.
people who have infertility. I've seen a huge change in how we address infertility, how we talk about it, how we share our story in the 10 years I've been on social media. Used to be faceless accounts and people not really wanting to associate themselves with their story. And now we're seeing such incredible bravery and vulnerability where people are sharing what they've been through. They are helping others not feel alone. And the infertility community is amazing and supportive of each other. And that really can change your entire experience if you are having infertility. But
Mm.
for somebody who has secondary infertility, they often report not feeling like they belong to that community because they do have a child. And it's not that they don't feel grateful to have that child, but it's that they feel like their family's not complete. And yet now they are having this hard time out of the blue. So I think it's important, just that you had a kid in the past doesn't mean you can just keep on waiting longer. But we feel more comfortable saying, oh, you can try naturally, for a few months if you're ovulating and your periods are regular. And then if you're not having success, come get an evaluation versus those people who are just starting for the first time, really, especially if they want to have more than one child. We really want to see them at a little earlier stage in the journey, in my opinion, because we just don't know. And it's really hard when somebody's been trying naturally for a period of time and they come in the office and you find out there's no sperm or the tubes are blocked or that it was never going to happen that way. And they feel like they were told they had to wait this amount of time before they could even get that information.
Oh, wow. I've actually never thought about the perspective of somebody who has a child and then is struggling with infertility on the next one. You're kind of in these both of these worlds or both of these groups, but also kind of on the line of them. That must be really challenging. I also didn't know that having a C-section can cause maybe complications with pregnancies down the road. So, would you recommend if it is safe for somebody to have a vaginal birth, if they want multiple children, to try to go that direction versus a C-section?
Number one, you should always listen to what your doctor is saying because, right,
Right,
everybody's different. But
of
yes, if
course.
we know somebody wants to have multiple children, that is why what we call elective primary C-section, a C-section for the very first child, is not the recommendation unless there's a medical indication because there are both pregnancy risks and fertility risks. So if we think about a couple of them, I have a patient who recently just had only her second C-section. So that's pretty common. I had two C-sections. But at the time of her delivery, she was found to have something called placenta accreta. And this is where the placenta grew into the C section scar and got so attached to the uterus that it couldn't be detached. That
Oh,
can cause growth restriction. It can cause issues with the pregnancy. It can cause a severe bleeding at time of delivery. She had to have a hysterectomy at the time of delivery, which is a huge procedure out of the blue, right? A bigger hospital stay because they couldn't safely detach that placenta. So we certainly see that the presence of such a big through and through incision on the uterus can result in difficulty with the placenta if it's trying to implant in that location. The other thing that we're seeing now in the fertility zone, especially as people are having many, many C-sections, is what we consider a defect in the uterine cavity where that C-section was. And this is called a uterine niche or an isthmocele. So essentially, instead of the layers being brought together, perfect, there's some gap in the bottom and not a complete muscle layer on top of it. There is a lot of research ongoing about this as we're trying to understand it, but we know in that presence, especially if there is fluid in it or abnormal bleeding, or depending on the size, there can be a lower rate of getting pregnant, a higher rate of pregnancy loss, a higher rate of potential the uterus rupturing at the site of that C-section scar. Some
Wow.
people have to go get that repaired, have another surgery before they can go get pregnant again. So it's not everybody that's had a C-section, but I do think it's important to know, right, that anytime we cut on the uterus, that has potential risks. The uterus, you only have one, and scar tissue or defects in healing really can impact the future if you're asking the uterus to, implant another pregnancy, have another placenta grow and expand a
Right.
baby. So that's really why, despite the fact that, C-sections, knowing when you're going to have a delivery is great, and walking in and a planned C-section is always better than an emergency one. But
Right.
that's why a vaginal delivery ultimately is safer for the vast majority of people. And why, if we know you're just starting your family and you want to have multiple children, why that could be the best option if it's possible. And this is why people are talking about a VBAC, a vaginal birth after a cesarean. So if you had a C-section,
Ah,
especially if it was for, oh, let's say your baby was breech, that they said, oh, you can't even try because it's not safe in this scenario, that you might be a good candidate to consider a vaginal birth in the future, especially if you want a bigger family. And I think that's just an important discussion. There's no C-section shaming. Again, I had them.
yeah, yeah,
And I think they're, they're probably one of the things in modern medicine that has changed maternal health dramatically. So
right.
it's amazing, but it's a big surgery. So I do think that it's something to have an honest discussion with your doctor about your future goals. And if that's what you need, that's what you need. But if there's a decision-making point, should you try a vaginal first? That's definitely what the research would show for most people.
You are blowing my mind right now. I'm already learning so much. I'm a C-section baby, and I was actually talking to my mom about her experience, and she said that C-section was very common when she was pregnant with me, and a lot of her circle was getting the C-section.
I definitely think there was a time period where C-section was almost being offered. How do you want to
Yeah,
deliver, vaginal or C-section?
right.
And I do think that we've seen kind of the bounce back after everybody had C-sections.
Yeah.
Interestingly, we're also seeing a generation of women who want to have bigger families than in the past. We've seen the total family size go down, and we're starting to see, I see this with my patients, right? Patients who are my age, most people, 2 kids was pretty standard max. And a lot of the patients who are a decade younger are really saying they want to have 3 or 4 kids. They really want to have a bigger family. And so I do think we have to approach both from family planning, when should you start trying, when should you test fertility, and delivery, how that goes into the conversation as we are starting to see generational changes in what people want for their family size. But I think the standard now is attempting the vaginal birth unless there's an indication for the C-section.
So interesting. Yeah, she had said to me that she felt she was kind of scared into a C-section, especially because I was almost a 10-pound baby. So maybe that was part of it too, I
Yeah, they might.
imagine. Right?
10 pounds
Who
is kind of
knows?
big,
Yeah,
so there's
that's a
definitely a reason.
I was a big one, yes. So you mentioned that you're a parent, that you've had C-sections. What was it like being pregnant and also having all this knowledge of pregnancy as a doctor, or I don't know, at the time that you got pregnant, studying all of this? Was it helpful? Were there certain things that no amount of knowledge could prepare you for?
Oh, it was terrible. It was terrible. So I had pregnancy loss. I had 4 miscarriages before I had my 2 kids. Had my children both in fellowship, so when I was training to be a fertility doctor, but already an OBGYN, and really felt, despite being a professional and in the women's health space, felt very unprepared for the, infertility journey, and then all the fear that came with pregnancy, the second guessing yourself, and really that stage of understanding, on this end, what so many of my patients go through, but also this idea that it never gets better. The anxiety, the fear just kind of is a moving target, going from, oh, well, when I get to this stage, I'll feel better. When I get past the first trimester, or when I get past anatomy scan, or when I get to viability, or when the baby's here, and just understanding that refocusing that the anxiety is really just a sign of something matters a lot to you. And as a parent, it just totally shifts. I was very fortunate to find physicians that I trusted who allowed me to be a patient and not a doctor in my own care. And that's important because it's really hard as a physician to be a patient. It's hard to not overanalyze things or go research them on their own. But also, the lifestyle of being a physician is really terrible. I mean, we physicians have double the rate of infertility as the non physician population, have a higher risk of pregnancy complications, of growth restriction and preterm birth. A lot of it probably lifestyle, stress, delayed childbearing. But my oldest, my daughter, she was growth restricted. She had decreased fetal movement. I operated and then I did my own surgeries on patients and then went to my OB appointment. And they, suddenly it was like, hey, she's not doing well, and quickly got into the camp of going to the hospital, having a C-section that night. And it was just very overwhelming, even as somebody who knows so much and can put things in perspective. And I think on the back end of it, it does give me a lot of insight to remembering how scary it is as a patient, and making sure the one thing I never loved as a patient was being given choices. And it doesn't mean that you don't want to understand what the choices are, but when you're given choices, you feel like there's a right and a wrong, just like choices on a test. And what I really loved when my physicians did is say, here's all the choices. Here's all the things we could do. Here's pros and cons. And this is why I recommend this one. Right? They gave me the autonomy to say I didn't want that one, or to discuss other choices more, because I knew they existed. You can't advocate for something you don't even know exists. But they also gave me the courtesy, decency, of giving me their recommendation and why, which allowed me to say, okay, these other things are here. I can explore them if I want, but this is what my doctor thinks is the best thing. And that really stuck with me, because a lot of people don't do that. They say, well, we could do this or do that, and there's no difference. So you choose. And that just feels like really big choice sometimes, when you're a
Yeah, my
patient
gosh.
navigating that health decision. And so I just always view my patient care, and I really try, when I talk to people who maybe are having infertility or going through a fertility treatment somewhere else, they're not my patients, to say, it's important that you know what the choices are, right? Your doctor might be recommending the perfect thing. You don't want either end of the spectrum. You don't want to just be said, here you go, you choose. You also don't want a dictator who just says, this is what we're doing, with no further explanation or rationale to why. So I do think it's important, if somebody is, listening, and this goes across all healthcare, not just fertility, to say, when you're trying to decide what's the best next step for you, if somebody's not telling you, you can say, like, well, what are the other choices? Why are you recommending this over other options? Because that is letting you know they're personalizing this to you. This is not just like a generic recommendation.
Yeah.
Also gives you insight to what else exists in case this doesn't seem like the right choice for you. And if somebody's just giving you choices, I also think it's fair to say, well, what would you do if you were in my shoes? Or what would you recommend for a family member and why? Because I think that that's a lot that's missing sometimes. I see patients just be told this is the only choice or being told here are the choices you choose, almost like their doctor doesn't care. And I think that that's something that's hard across medicine right now, no matter what the field is. And
Yeah.
really saying that, it's your body, it's your health, it's your fertility, it's your hormones. If you're going into menopause, it's your life, it's your body. You're really the only one responsible for what happens. And you owe it to yourself to understand your body, to know how to advocate for yourself, to find physicians or care teams who can help you along that journey. And if you're not in a place that is meeting your healthcare needs, like go get another opinion. Please, please, please.
Absolutely. Oh, such great advice. And thank you so much for being willing to share about the losses that you experienced. I can't even imagine being on the path to being a fertility doctor and also experiencing these at the same time. Were you already on that road, or did you pivot once you were experiencing these things?
No, I was already it's a very long process. It's a 4-year
Yeah.
OBGYN residency, and then you apply, you go interview all over the country. I did research in a fertility lab. And so I started trying to get pregnant around the time I was in, the application process. So these losses all happened, once I was hopefully going to be a fertility doctor or had matched to a program or I was in fertility training. And
Wow.
it was shocking to me how even as an OBGYN, how I was turning, I mean, these were like early internet days or
Yeah.
earlier than now where you get more information so easily, but I was turning to the questions I had as somebody going through it were not what was in my textbook and not things that I knew. And so it's like, oh,
Mm.
I'm a doctor, I'm an OBGYN, and I don't know the answer to this question about my miscarriage, and the book doesn't say it. And really turning to online, and that's back in the days of more like forums and blogs where people were sharing their experience, and really was one of the first things that later propelled me to start educating online and say that I know people are wanting more information and looking for it. And even though maybe people don't go to Instagram to learn about their egg count, it can
Right.
be, oh, I mean, now they kind of do, but like,
Not yet.
y-
Not yet.
but I mean, like, I felt like, well, but
Yeah.
you kind of need to know some of this information when you're not looking for it. And so that's always
Mm.
been one thing that I've tried to do and always think about is how can I help reach people earlier in their journey? How can I give them more education so that they can make different choices or advocate for themselves better before they're sitting across from me in the office? And you know, that's why there's now so many of us, I think, on different social platforms trying to talk about your health, your body, because it's really hard to get that information. And we're trying to improve upon all the misinformation that we know is out there.
Yeah. About like the language of miscarriage, do you feel like calling something a miscarriage is almost shaming towards the female that, they did something wrong or they lost something? Like, do you think that the way that we talk about these things needs to change? Or what would you call it if you feel like there should be a change on that?
I've never personally felt that way. I mean,
Okay.
from a medical standpoint, they're all abortions, right? And that rubs people a very wrong way, whether it's a spontaneous abortion, a missed abortion, a threatened abortion, an incomplete abortion, elective abortion, a therapeutic abortion. Those all are like medical words. So when I'm writing in somebody's chart, that's actually what we're saying, right? Because an abortion is a pregnancy loss.
Mm.
And those are just different stages along the way of when and how it happened. And I think that the abortion word is very charged for people. And so I think that definitely makes people feel a lot of different feelings about it, even though it's literally diagnostic code you have to write into your medical note.
Yeah.
But I think from the miscarriage standpoint, I've always understood that some people feel very sensitive to it. It didn't matter what you called it. I felt huge shame. I felt like my body was failing me. I was a failure. I couldn't achieve this thing that I'd almost always assumed would be in my life. I had these two big life goals. Want to be a doctor, want to be a mom. And you think about to be a doctor, I knew what that path looked like, right? What tests I'd have to take. I'd have to major in this. I'd have to take an MCAT and shadow and get into medical school. Like I had a plan. And this other goal, which was arguably more important, the plan was let's prevent it. I'm going to take birth control until I'm ready. And then I'm just going to hope it happens because that's how we approach our fertility.
Right.
And the idea that, gosh, my husband and I were married years and years before we started trying to have a family. So I really carried a lot of guilt and shame. But we could have started earlier if it was going to be this hard. I was the one, I'm in training. This isn't a good time. This is too hard. And those things are all true. However, faced with this idea that I wasn't prepared for how hard it would be, yet it was such an important thing. And being faced with the fact that you might not be able to achieve it was very, very overwhelming because I couldn't picture what my life would look like without being a mom.
Mm.
And, that's been something I've always tried to reframe how we discuss our family, how we discuss our family planning, why there really shouldn't be any shame in talking about all of this because it brings the conversation earlier so more people can have information and make choices earlier. But, the miscarriage word, the pregnancy loss word, I had an ectopic pregnancy. The verbiage itself didn't matter to me because just going through it was so charged with guilt and shame by itself and so isolating that there's no word that would have made it better in my mind.
Makes sense.
You mentioned there's a lot of misinformation out there and weird hacks. I don't know, that may or may not be true. This is why you're here to help us clarify some of this. So let's see. Putting your legs up in the air after sex. Let's talk about it. I mean, is this a medieval rumor that's going around? What are we dealing with here? Is this helpful?
One of my favorite patients gave me the fertility practice. I started fertility practice with a partner 4 years ago. It's called Fora Fertility, and our color is blue. And one of my favorite patients gave me this troll doll with blue hair that like sits on my desk to remind me that like no matter what you do or how factual you are, like the online trolls are always going to spew misinformation
Oh my
and people are going to
gosh,
like
that
fall
is
for it.
so fun.
So I think it's important to talk about some of these things. There's
Yes.
nothing wrong. There's nothing wrong with putting your legs in the air if that is a desirable option for you. It makes no difference in your ability to get pregnant or the idea that it helps facilitate sperm and egg meeting. When you have intercourse, sperm is deposited in the ejaculate into the vagina. The ejaculate is protective. It's alkaline against the acidity of the vagina. And the sperm swim out of it like so quickly. They will be seen in studies. They can be seen out the ends of the fallopian tubes within like a minute. So
Wow.
they are like whoosh through there. And then we know sperm can live in the female reproductive tract and the cervix and the uterus for up to 5 days. So there's no need to have this idea that you need to, one, no position when it comes to intercourse is superior to another. As long as ejaculation is happening, that's what you need for conception. Two, you don't need to be putting, your legs up. You don't need to be laying flat. You don't need to avoid going to the bathroom. In fact, we know urinating after intercourse can decrease the risk of a UTI. And I'll see a lot of women get chronic UTIs because they're trying to get pregnant and they're waiting and having, UTIs causes inflammation and that's not desirable. So the sperm that have the highest motility, like the good guys, they're out of there. So just you do what you want after sex. You want to cuddle, you want to pee, like go for it. You don't have to put your legs up in the air.
I love it. So good. Do people need to wait a certain amount of time to try to get pregnant after being on the birth control pill or I guess other methods to IUD, anything like that?
You don't need to wait any amount of time. And in fact, you can get pregnant really quickly after stopping any of those contraceptive options. There are circumstances, though, where I would say I like people to stop the contraception before they want to get pregnant purely because you're masking your body's cycle, your period, when you're on these. So you just don't know that everything's normal. And you'd rather have, a bigger runway to say, we want to be pregnant in 2025, but I stopped my birth control and I don't have periods now. So I need to go get that worked up so I can figure out what's going on. And then you're in front of it versus suddenly you feel like 6 months have passed and you haven't had an appointment yet. So I usually recommend for the birth control pill combined estrogen and progesterone. That works to stop you from ovulating. The birth control pill is so short acting, meaning missing one pill can cause your brain to send out enough hormones to ovulate. And that's why we know people who get pregnant on the pill, or they skip a pill and they can get pregnant. So there's no pill detox. I know that that's being sold online as a birth control
Yeah.
pill cleanse or detox. That's not a thing. So if you stop the pill, your body will resume ovulation if it can. We have to remember the if it can, right? Some people have PCOS, or they have like hypothalamic amenorrhea, and they just delayed the diagnosis because when they were on the birth control pill, they weren't ovulating. They may have been bleeding because of the hormones in the pill and how they were instructed to take it. And so that gave women this idea, I have regular periods, but I'm on the pill, so it's all fine. And then after the fact, when they don't have a period or they got diagnosed with PCOS, there was this whole movement of people saying the birth control pill gave me PCOS. It's not true. You had PCOS the whole time. It's just the birth control pill was masking some symptoms, treating some other symptoms because it can lower your testosterone level. And so it was more of you weren't able to get to that diagnosis till later. So if you're on the birth control pill, that's not going to impact your future fertility. There's no higher rate of infertility if you've taken the pill, even long term. But I like people to stop at about 3 months prior, because understanding you don't know what your natural ovulation is.
Right.
If you've been taking the birth control pill for a very long time and you're not having periods, so some people will take the pill continuously, like skip the sugar pills, or they'll have a period maybe every 3 months because they're just really taking active pills. That's perfectly safe. That's not problematic, but that can thin out the uterine lining more because you're never giving the uterus a break from that constant progesterone exposure. And that might be why people start having very, very light or no periods. In those circumstances, I usually recommend a little bit longer, 3 to 6 months off the pill, because that uterus needs what we call unopposed estrogen to grow. The first part of your cycle, when your body's growing an egg, you just have estrogen. After you ovulate in the second half, you have estrogen and progesterone. And then when you're not pregnant, that progesterone drops, and that's a sign to your body, not pregnant, have a period, and restart over. But if you're on birth control pill, you just have constant estrogen, progesterone every single day. You take the sugar pills, progesterone drops, so you'll get a bleed, but you're not really growing that full lining that you would otherwise. And that's fine because you're not bleeding as much. You don't have as bad of cramps. It can be fine. Same thing with the progesterone IUD, understanding that's progesterone only. So Mirena, Liletta, Kyleena, you're putting something in the uterus that's giving daily progesterone all the time. And we often see that uterine lining thin out a significant amount. And that's why people with IUDs very often won't bleed if they're on a hormonal IUD. Sometimes they're still ovulating because that progesterone may not be high enough to stop them from ovulating. So sometimes people will get a spotting here and there. So I like a progesterone IUD to come out 6 months before you want to get pregnant, because it can take a while to get that uterine lining to build up. And specifically, if you have no bleeding on the IUD, like that was awesome while you had it. But we want to give your body time to know what other issues there could be. Important note, Depo-Provera, the birth control pill shot, which is less common now than it used to be. That was the shot that you would get every 3 months, high progesterone dose. You need it every 3 months to have a high enough progesterone in your system to know you're preventing ovulation. However, a single shot can prevent ovulation for up to 18 months. And so I've definitely seen patients who maybe took that shot a year ago and now they want to get pregnant and they're not having periods and they're very confused why. And it's because they still have some of that in their system. So Depo-Provera, the shot for birth control, is only in a circumstance where you're remote from wanting to have a family, like 2 years plus before you want to have a family. Same things like, implants is a progesterone only, like the Implanon or Nexplanon that goes in the arm. That's a progesterone only, but you can take it out. So it's a little bit easier versus the shot. Once that's in your system, it's in your system. And I see why it felt like to people the pill was causing it. And truly, generationally, right? A lot of these women got put on the pill at 15, 16 for XYZ
Same, yeah,
reason, right?
yeah.
On it for 10, 15 years, get off
Wow.
of it. And then now they have these irregular periods in their brain. They're like, I never had irregular periods. I didn't have acne. Now I've gained weight. It's all the pill's fault. But really, that person had PCOS. They never got diagnosed because people weren't diagnosing it in teenagers then. You got put on the
Wow.
pill and just kind of masked it, which was fine. You didn't harm your body at all. The only harm was that you didn't know. And so now suddenly you're kind of trapped in this getting your diagnosis delayed and not feeling prepared versus if you knew you had PCOS and you were on the birth control pill for it and you wanted to be pregnant, you're going to be making a different game plan. Okay, well, when I come off the pill, my periods might be irregular. What things should I be doing? How long is too long? Should I go ahead and talk to my OB about medication to help me ovulate if I'm not ovulating? So it's just more about that same concept of understanding your body. It's not that person's fault, right? That was I was put on the pill at 15, right? I think
Yeah.
so many people were, and there really wasn't a discussion about why. And one reason is contraception, right? But a lot of times it's you went in for bad cramps or abnormal bleeding, and it was what was given without a further discussion. I also
Right.
think it's fine for people to go on it and for a doctor to say, hey, we could do XYZ workup to figure this out, but that might not be worth it to you right now at this age. So we're going to do this, but understand that these problems will likely still be here later. So we should stop the pill, but well before you want to have a family so we can get to the root cause. And I think our
Right.
mindset would be totally different if we had that approach to contraception or hormones. Because if you knew that, you very well might at 16 say, that doesn't matter to me now. And that's fine, right? Why should you have
Right.
vaginal ultrasounds or blood work testing if it's not going to make a difference to you at that moment? But not knowing that, that you have this thing or that you likely have something and then being just shocked with it later is putting people at such a disadvantage.
So interesting. Yeah, I went on the pill at 15. I went in, I think, for acne, also heavy periods. And instead of like, oh, what's the root cause or what's going on? It's just let's put you on the pill. So that totally makes sense that maybe, the thing that was going on maybe wasn't solved or it was hormones or whatever. What about like some of the foods you hear people should eat during pregnancy, like pineapple or Brazil nuts or I don't know, stuff like that? Does that stuff help? Are there things that actually help? Or is some of this bullshit? What's going on here?
I mean, pineapple, yay, it's a fruit, and like Brazil nuts are so good for you. So like these things are never bad for you.
Yes.
The reason why they've gotten like a little fertility reputation, pineapple core specifically, not
Oh,
the
okay.
outside, but the core of the pineapple is high in something called bromelain. Bromelain is an antioxidant and is a little bit of an anticoagulant, like a slight blood thinner. So the idea is that it's easier if you're eating pineapple core around the time of implantation for that placenta to implant into the uterus.
Interesting.
It's not proven to be helpful, or we would be giving pineapple core pills to everybody, but
Oh,
it's
yeah.
not gonna harm you, right? Pineapple is so good in a lot of vitamins and nutrients, but we don't know that, but that's why, pineapple core is not harmful, very safe, you absolutely can have it, maybe it will help. Brazil nuts are high in selenium, so also we're seeing that these things have, specific vitamins and nutrients that might be harder for people to get otherwise, and that's why they get a little bit of a reputation for being helpful at certain times. So selenium and vitamin E, which can be really good for the lining, so we see those recommended in the luteal phase, like 1 Brazil nut a day in the luteal phase, you'll hear people say that.
Mm.
When it comes to science and studies, it's really hard to study fertility. What's your outcome? A positive pregnancy test, a pregnancy on ultrasound, a live birth. It's very nuanced. Two,
Mm.
diet and nutritional factors are very hard to study because people who eat Brazil nuts, for example, tend to have other dietary patterns, which are ultimately better than people who
Oh,
eat bacon, right? And so there's a
right.
lot of nuance into trying to study a specific food or a food group. What we see consistently, diets that are higher in fruits and vegetables have a higher association with ovulating and getting pregnant. Diets that are high in healthy fats, so the avocados, the nuts, the olive oils, those do markedly better than your saturated fats, some of the trans fats.
Mhm.
Um, processed meats, things that are highly processed in general, and processed foods, sugars and refined sugars are all associated with lower chances of fertility than having less. And a lot of the diet studies look at levels of exposure. So we'll use meat, for example. You look at people who have the least exposure to meat, you kind of group them into fours, right? We'll say people who eat meat every day, people who eat meat, 4 times a week, 2 times a week, and none. So people get put into these 4 groups. And they often look at the exposure in the highest group and the lowest group to kind of draw some of these conclusions. So people who ate the most meat versus people who ate the less meat had lower rates of embryo development in IVF, lower rates of normal embryos. Does that mean meat causes abnormal embryos? Like, I don't think that's the loop, but I do think there are certain associations we can say with people who ate the less amount of meat probably had a lot more vegetables and fruits and other things in their diet as well.
Right.
And some of these meat sources might be things, put into very processed packages, right? And so a lot of studies don't really differentiate in some of those things. So the quality of the food's going to matter a lot. And whole foods are always going to be better than the processed and the refined foods, added sugars. Those things do carry negative associations. Do people get pregnant eating McDonald's every day? Yes, right? But especially if you're trying to take control of what you can, or if you're having infertility or you're going through fertility treatments, you want to set yourself up into the highest odds of success. So you do want to put, high quality food into your body. You want to avoid toxins to the ability that you can. You want to know that you're giving your body all the building blocks it needs to grow a little human. It's really the whole picture of your diet that's going to matter a lot.
Right.
The people that come to you for help, and let's say that they've explored all of their methods and they just are not able to conceive, what percentage of those people end up adopting a child?
I'm sure I have huge selection bias because I see people with infertility, and a lot of them may not even come my way if they know they want to go down the pathway of adoption. I
Right.
do know that in today's society, a lot of patient groups are excluded if you want to be, a single parent by choice, if you're in a same-sex relationship, if you had a prior cancer diagnosis in the past decade, you might not qualify for an
Oh,
adoption.
wow.
And so there's people who I think would love to adopt, and yet it is either financially or logistically can be extremely challenging for them. I definitely have patients who have adopted or who have fostered. I have patients who, have a blended family where they maybe had success with one child from IVF and then decided they were going to add to their family in other ways. And there's no one way to do things. There's no right way. We also, right, there's egg donation, there's embryo donation, there's a lot of different ways we can create families. And the one thing I always tell people is that genetics are probably the least important thing that make a family, and that allowing our brain to be more open to other family structures if we have a strong desire to be a parent is very, very important when you go through this journey. Doesn't mean you have to choose one thing or another, but being open to learning about that. And I say that to people who even say, I don't believe in IVF. So my job's not to convince you to do it, but my job's to explain it to you so that you know it's a choice and then you can decide if it's right for you or not. But if you won't even hear the discussion, you're really doing yourself a disservice because a lot of times, IVF, for example, there might be something along the way that we can modify that makes it fit your needs better, fit your ethical, moral, religious beliefs better. So I always like to take the view that your responsibility as somebody going through this is to be open to what's out there to learn about it. Because if you
Yeah.
learn about it, then it's easier to say, that's not right for me. I know what that is, and that's not what we want to do. And you can shut that door feeling more confident because you were educated about it. But to not even allow yourself the opportunity to learn what that option might be, especially if you really strongly desired to be a parent, I think is just really a disservice because there's a lot of unknown when it comes to a fertility journey if you're experiencing infertility.
Yeah. Oh, such great advice. I have one more question for you that I'm just curious from your perspective. If you had all the funding in the world for like a certain research study, is there any gap that you think needs to be filled? How would you spend that money when it comes to the topic of fertility? What would you want to find out?
Oh, there's so many, but when it comes to IVF, a single genetically normal embryo has a 65% live birth rate, which is really high in the field compared to like natural fertility rates. But it's mind blowing that it can look perfect under a microscope and its chromosomes can be normal, yet still 35% of the time it's just not going to work. That's still a really big number I feel like there's a big gap in what makes an embryo have competency to really turn in to a baby, right? Even when we have these
Yeah.
embryos that look beautiful, there's a lot of competency. And is it on the embryo's end or is it on the uterine receptivity end? Like where is that mismatch happening? And not that there's not a billion like lifestyle topics or early fertility topics that I would love to dive into. This one is near and dear to me because, having somebody walk through an IVF cycle and get to a transfer, and even if we say not every transfer is going to work, it often takes, more than one to get there. It's hard because the rate limiting step for so many people is having enough embryos to be able to have the right opportunity. I guess I'll also add if we could like extend the ability to have, our eggs longer, maintain their quality better, right? Delay menopause. I know there's a
Oh,
lot of
yeah.
research going into that right now. And, it's twofold, right? Menopause is about running out of eggs, therefore you don't ovulate and make estrogen. So that's more of a one end of it. But from a fertility standpoint, if there was a way to preserve some of that genetic normalcy of your eggs longer, it would really be revolutionary for the ability to grow your family.
Amazing. Thank you so much for your time today. This has been invaluable. I've learned so much and I still have a million more questions for you. We would never get to all of them. But do you have any final kind of words of wisdom for people who might be trying to conceive or maybe feeling discouraged? And then, of course, where can people find you, your podcast, your work, all that good stuff?
Thank you so much, Delaney. I just think it's important for people to know they're not alone, even if you feel alone. And if you don't feel supported on a medical standpoint in your journey, there are different doctors. You're allowed to get another opinion. You're allowed to find somebody else. You need to make sure that you're getting the care that you deserve because your fertility is finite and you want to make sure you have the opportunity in that window to have the family that you desire. And I have tons of fertility, content all over the place. I'm on Instagram and TikTok at Natalie Crawford MD, and I have a YouTube channel, Natalie Crawford MD. I have a podcast called As a Woman, which goes in depth on a lot of these topics. And there's also a Q&A segment we do constantly where people can call in and leave voicemails. And then I practice as somebody is looking for a fertility doctor at Fora Fertility in Austin, Texas. And just thank you so much for having me.
I know you probably still have a ton of questions, especially very specific questions based on your situation. So definitely go check out Dr. Natalie's podcast, social media, submit the questions that you have for her. She's already covered so many topics. So I definitely recommend sifting through her stuff to see if she's already answered what might be on your mind. And we've done a lot of episodes kind of relating to this topic on, matrescence, childbirth, postpartum, pelvic floor health, parenting. So if you click on this episode's description, you will see a bunch more self-helpless episodes listed for you that relate to this topic if you want to keep digging into it. And one thing I didn't ask Natalie about since we ran out of time, but I really wanted to know more about it, was the fact that the US has such a high maternal mortality rate, especially compared to other high income countries and nations. And I went on Natalie's stuff just to see if she had talked about it, and she does share some information about why that's the case. And so, if you're interested in that, she does cover that, and it's a lot about how our healthcare system operates. So please look into that and learn as much as you can about it if you are somebody who wants to try to get pregnant. And I really hope that you can be, your own best advocate during that process and call on the people in your life to support you. Also, something cool, Dr. Natalie told me that she has a book coming out soon. So stay tuned on, her website, social media, email list, whatever you can join for more information about that when she is able to share more about it. And during this episode, it really made me realize that the people in my life who want to have kids or, have kids, they seem very in tune with what's going on with their body in that sense of things. Like they know their egg count. They're very on top of those types of checkups for that part of their health. And it's really made me think about the fact that because I don't want to have kids, I don't really think about getting all my stuff checked in that area. And maybe this is just a good reminder for those of us that have decided not to have kids to make sure our health is solid too, and get things checked if you can. I also know it's a privilege to have access to healthcare. But your health really matters, and I know for me, I just have not been focused on that part of my body at all, and I definitely want to shift and make that more of a priority. So haven't had a physical in a while. I need to make an appointment, and I really hope that you can take great care of yourself, whether you want to have children or not. And I'll leave you with just a little update and the Apple Podcast review of the episode. So you may have noticed, whether you saw, maybe a clip of this episode, or maybe if you tuned in on YouTube or something, but I just feel like I should address it. Yes, I dyed my hair brown. I am now a brunette. And I would definitely call this more of a self-careless / the fuck moment for myself, because I several months ago decided I was going to go back to my DIY ways of cutting and coloring my own hair and doing my own nails and all this kind of stuff. I'm at an age where I don't know if you guys feel this way. I'm tired of going to the salon. And it wasn't always something that I did, but I went through a phase where I'm like, I should probably do this. It's what I'm supposed to do, blah, blah, blah. And I'm just kind of over it. I don't feel like going, I just want everything on my body to be low maintenance and kind of as natural as possible now. Is this like an age thing, you guys, or is this, do you go through phases? I don't know. And so I accidentally dyed my hair piss yellow not too long ago. Maybe you can look through some episodes, you can see which ones I'm talking about, where I was, I had kind of like a highlighter, and then I just decided that I would try to dye it brown and just let my natural hair grow out, which is kind of a dirty blonde color. So I tried to correct it, and now it's kind of like this shit brown color. So I don't know where it's gonna fall, but I'm just gonna leave it. I'll let it fade on its own. Hopefully, it kind of shakes out to something that is close to my hair color, and I'll keep you posted. I definitely fucked it up. I have a newfound respect for hair colorists and stuff. I think you guys are amazing at your job. I just don't feel like going to a salon and sitting there for a couple hours. So it's nothing against how great you are at your job. It's just really my own preference for wanting to stay inside my home. So there's definitely parts of it that's kind of gray, green. It's not great, but it does the job. It works. It's fine. And then yeah, I've just taken all my nail polish off and stuff, and I just want to just let things grow out and let them be, and not put chemicals on them, and just see how that feels. So I think this is me now, and I'm in this phase where I don't really care what's attractive, or quote unquote attractive, or what people think I look good in. I just want peace, I just want things that don't take much effort. It has nothing to do with what may look the best on me. I want as little energy going into it as possible. That is what I need at this point in my life. Also, if you've been listening to the podcast for a while, the fact that I am back to my DIY ways of cutting my own hair, things like that, just don't tell Kelsey and Taylor yet. I'm going to have to break it to them gently. Kelsey's going to have to take some deep breaths and center herself. So there's my update for you. And the Apple Podcast review of this episode is from Mental Health Junkie, titled What I Needed. And it says, "This podcast is so incredibly validating. As a therapist myself, I enjoy the subjects you all explore, the kind and gentle way it's spoken about, and the freaking hilarious tone added to everything." Thank you so much, Mental Health Junkie. This really means a lot, especially, the fact that you work in the mental health field. That's awesome to know that this is helpful to you or resonates with you. And thank you so much for taking the time to leave a review. If you want to leave a review on the podcast, I'll read it next episode. I'll get a chance to say hello to you and thank you personally for it. Hope you have a lovely day or night whenever you're tuning into this. Talk to you soon. And any of the males out there, remember not to hoard your loads if you're trying to make a baby. All right? Okay, everybody. Bye. Thank you for tuning in to Self-Helpless. You can find our brand new merch, Patreon community, and other fun goodies at selfhelplesspodcast.com. We'd be thrilled if you left an Apple Podcast review, shared this episode with a friend, or post about it on Instagram and tag us at Self-Helpless Podcast so we can repost you and say hi. As an independently produced show, we sincerely appreciate your support. Thanks, everybody.